This conference will now be recorded.
My name is Grant Dearborn. I'm with the Shumaker, Loop, and Kendrick firm. Wanted to welcome you all today. Wishing all of you who have served our country happy Veterans Day. Those of you who are married or the children of veterans, wish you well also. Those of us in Florida are right now buckling down for a storm. So I definitely do appreciate those of you who have called in spite of that situation. I do note that we are recording this today. So if you actually want a recording of it, we can ship that to you, particularly if you have other folks that you know would like to watch it, or we can send it to them directly if you want to shoot us an email or connect us with somebody. Again, my name is Grant Dearborn. I'm a board certified healthcare lawyer in Florida. I'm also certified in compliance privacy, and I've been doing healthcare for, oh gosh, about 20 years. And so appreciate that opportunity I had. I've worked for the government and in-house and law firms, obviously. Speaking, co-chairing, co-presenting with me today is Mary. Mary, you want to introduce yourself?
Good afternoon, I'm Mary Ramsay. I work in the Charleston office of Shumaker in South Carolina on the healthcare team. I've been practicing for a little over 10 years in some litigation as well as healthcare compliance, but been pretty much healthcare for the last 3 years or so. I am certified in HIPAA privacy and security, and I look forward to giving y'all the update that Grant and I put together.
Thank you. So I would like this to be participatory. So if at any point you would like to ask a question or you have a pertinent point to make, one of the reasons that you all were invited is either I knew you and knew that you are very qualified and capable compliance folks, or somebody that I knew said that you were super professional people and would be able to add to any conversation that a group wanted to have. With that, let me just take a minute and say, Odalis, you want to take a moment and introduce yourself?
Yeah, I'm Alex Meyer, and I
just taking myself off of mute there. Hello, everyone. My name is Odalis Capote. I'm currently serving as the Vice President Compliance Officer and PMO and Quality VP at M2Gen, which is a subsidiary informatics subsidiary of Moffitt Cancer Center in Tampa. I have been within the Moffitt system for about 28 years in different roles, including the founding compliance and privacy officer there way back when, served in that capacity for several years, and then went briefly to USF to begin their compliance and ethics program. And then had the opportunity to return to Moffitt as the Chief of Staff for the Cancer Center Director and CEO for several years. Following that, in 2012, moved over to M2Gen and initiated their compliance activities. It's not a healthcare provider, it's not a covered entity, but the company dealt with big data, molecular data, and clinical data from 18 cancer centers from around the country as part of the Oncology Research Information Exchange Network. So as Grant said, throughout this whole career, I have had the fortunate opportunity to work with Ron Cristaldi and Shumaker Loop in particular with the M2Gen position, and appreciate Grant inviting me to participate in this. He knows I'm very passionate about compliance and privacy, and hopefully this will be beneficial to everybody on the call and those outside as well. So thank you, Grant.
Thank you. Nicole, do you want to introduce yourself?
Oh gosh. Okay, I'm Nicole Devonzo. I'm the Payment Integrity Director at Health First Health Plans in Melbourne, Florida. I have been in compliance for approximately 6 years. Currently, under my umbrella of payment integrity, I'm responsible for the Special Investigations Unit and anything related to the integrity of our claims. I'm a nurse, a registered nurse by trade. I have been in roles from public health nursing to practice management to compliance, lastly, over the last 20 some years. So I'm pleased to say my student loans are finally paid off, but I now have new student loans with my children, and I do miss interacting. I'm just thrilled to see Grant's face. He by far is the best compliance collaborator I have ever had in my days, and I must say he was one of my dearest bosses. So, and he didn't pay me to say that. So I'm happy to be here today. Looking forward to always something to learn in compliance. Correct?
Yes, and thank you. Rachel, would you like to introduce yourself? Okay, Cheryl, how about you? Would you like to introduce yourself?
Hi, how are you? My name is Sheldon Gregory. I have a master's degree in nursing education, a BSN, and a JD. I work with Grant as an integrated delivery health network. I've been a nurse since 1997, working mostly recently in risk, compliance, quality, and HIM, doing utilization management. I've worked in the hospital setting as an ER nurse, ICU, occupational health. I worked in behavioral health as their compliance officer for an inpatient involuntary facility in California that took care of adults and youth. I have taken care of telehealth, building telehealth programs, and I do currently consulting for mostly crisis management and program building. And thank you for having me, Grant.
Thank you. Skyler, you, I think, get the award for the farthest away. So you want to introduce yourself?
Yep, I'm Skyler Adams. I live in Kearney, Nebraska. My CEO reached out and invited me to this. I'm looking forward to it. I'm pretty young in the field. I have only been certified for a year in HIPAA privacy and security, but my focus is mostly privacy. I'm currently the HIM manager at a new hospital that we're just coming up on our 7-year anniversary for the hospital. So needless to say, I have a lot to learn. So I'm excited to hear all of your guys' input and learn. So thank you.
Welcome. Karen?
Hello, yes, my name's Karen Bolton. I've been an attorney for, now 30 years, and I've been involved in compliance for 16 years now. And I've worked as general counsel at various hospitals. And currently I work as general counsel and chief compliance officer for a physician group of anesthesiologists, and I had the good fortune to work with Grant when I was with Health First, so that's how I know Grant. But I'm excited to chat with everybody today about compliance and all the things that we need to be doing, and be vigilant against to protect our organizations. So I'm glad to chat with everybody here.
Thank you. Joshua?
Hi, Grant. Hi, everybody. Grant, thank you for having me today. I always like an opportunity to collaborate with other compliance professionals and learn best practices and so forth. And so I was really excited to join today, especially being holed up in this pandemic, just doing something that's a little normal that we used to do all the time feels really good. So my name is Joshua Boxer. I'm the Chief Compliance and Chief Privacy Officer for Integra Connect. We're a value-based care software platform, EHR, population health, revenue cycle, and life science analytics, really in the oncology space, primarily community oncology, but we do have some academic systems as well. So, we fancy ourselves a data company startup, and yet we also have, long story, I have a very entrepreneurial founder. He bought many years ago the CBO for the largest ambulance company. So we also do probably the most number of revenue cycle ambulance trip billing in the world. But that doesn't really mix with our, when I do the elevator pitch. So I try to do that separately as best as I can. But nice to meet everybody. I'm a board certified healthcare lawyer, been in compliance for 5 years. Prior to this, I was in compliance at the University of Miami Health System. And prior to that, I was an assistant general counsel at UM, as well as part of, with Broad & Cassell, and then for many years in a boutique firm in New York, all physician, healthcare, regulatory operations type work. So really excited to be with you all and some really impressive people here. Thank you for having me.
Alex.
Hi everyone, my name is Alex Meyer. I'm currently serving as the Associate Compliance Officer at Physician Partners, which is a managed care organization located there in Tampa. I was recently admitted to the Florida bar, and I'm relatively new to the compliance landscape, and so I'm just excited to be here and get some ideas as we expand our business into some wholly owned clinics there in Central Florida.
Welcome. Autumn?
Hello, everyone. I'm Autumn Smallwood. I'm the Director of Compliance at Moffitt Cancer Center. I'm attending in place of Danetta Horseman, our Chief Compliance Officer, who was unable to attend today. So thank you, Grant, for extending me the invitation. In my current role, I'm responsible for the research compliance, privacy, and conflict of interest programs at Moffitt. I've been with Moffitt for the last 7 years. I started on the research side and moved into compliance about 4 years ago. I've only been in my current role for about 6 months, and prior to that, I served as the conflict of interest officer. So I'm very excited to be here and to learn about more about compliance from all of you very experienced professionals. So thank you.
Well, thank you. And did I miss anybody?
I apologize. This is Rachel Birkin. I was putting out other fires while trying to join as well. I work for ProMedica in Toledo, Ohio. We have a large health system of acute care hospitals, physician group, academic affiliation, senior care services. I am an attorney and also certified in healthcare compliance. I've been doing compliance for about 10 years now, with 6 of those being at ProMedica. So that's me.
Well, welcome all. And one of the reasons I really believe in these things is I think that we all, and I was a compliance officer for several years and worked with some of the people on this phone call. But I think connections are important. And I think being able to hear what other people are doing is also very important, as a couple of you mentioned. And those connections, can never be underestimated. I met Karen actually at a conference lunch. I think for some reason we just sat down and started chatting to each other, haven't known each other, and we've developed a friendship after all that time. And I don't remember if it was an HCCA conference or an AHLA conference. It doesn't really matter. But this connection is always good, and hearing from other people that have good ideas, and sometimes who can say, "Well, wait a minute, that might not be the best idea. You might want to do this a little different." Not a bad thing. Catch a bad idea before it gets out of the box. Because otherwise you end up with things like the Bay of Pigs and other momentous screw-ups in history. So with that, we move to the next slide. So I didn't list out 7 elements. I think all of you have seen those. You've read them. You probably like them because you've seen them so many times. But I wanted to talk about a few things around those. For instance, the OIG has nicely said that a compliance program is not a one-size-fits-all, and I think that's great that they say that. You always wonder if they actually mean it, but I think there are some things that you can talk about that are probably nuts and bolts basics that you frequently want to have as far as policies. One of the things that in the past I've created is a policy that just took the 7 elements and made it a policy. That way, I always felt like if the regulators ever came in and they said, you have an effective compliance program, you could say, hey, look, I even got a policy. It says, here's the 7 elements. And then built out from those what you needed for specifics for your company. So what your training policy would be a separate policy, but it would take off of that kind of umbrella policy. Auditing and monitoring. We all know that the auditing and monitoring you do today doesn't go to sleep. It often rears its head at some point, meaning that you have to do something, you have to correct something. Somebody might get fired, somebody might get suspended, might come up when there's due diligence done for an acquisition. So those things need to be driven to the degree you can by a policy so that you have some touch points where everybody kind of knows at least what the basic expectations are. And some of them are things that you should never have to say. For instance, that your investigation is going to be impartial, that you're going to review the necessary documents, but it's not bad to have those things in writing. Additionally, training, be it schedules or requirements. One of the big things I think that you always want to make sure you have in a policy or a procedure. What happens for those people who refuse to do their training? And I know all of you have never had that problem. Everybody always loves to sit through those annual multi-hour trainings. They don't scroll through things and just click on the buttons. Not ever a problem. There's never a person out of every 100 who just wants to be ornery and not do that. Again, the investigations, just like the audits and the monitorings, you want some kind of guardrails, some basics laid out so that everybody knows what to be expected. I think it also sets a tone with those people who are being investigated, audited, monitored, and it gives them maybe a little room to not be afraid that you're going to go off on a jump. I think it also establishes, to me, a level of professionalism. This is what we do. This is what we're going to do. And this is how we operate. If you have a very sizable program, I think you want a compliance program charter that kind of lays out the mission, the values, and your vision. Additionally, if you have a committee, compliance committee, a charter for them, I think it's a good starting point for the committee because they have something to know. This is kind of our touchstone document that we're operating on. The document will tell them things like, who does the committee report up to? Is it to a senior executive, or is it to your board? Or if you have managing members, is it to them? I think it gives them a sense of purpose and also a sense of where they fit in the world. I think, as I've mentioned, discipline and code of conduct somewhat go hand in hand, but I think they're things that you need to have laid out so that everybody kind of knows the rules of the road. And I think for employees, staff, volunteers, whoever else might be in your facility or involved with your company, that they all know what are the ramifications if they don't behave. The lines of communication, I think, are probably most important for the employees. They're most important also, though, when the government does knock on your door. And we do know that OCR these days seems very fond of sending out letters. I'm not going to take a poll, but if I asked all of those on the phone who do privacy, raise your hand if you've gotten a letter from OCR. There probably wouldn't be many of you who didn't raise your hand. They love sending out letters. The best thing, I think, is they always like to tell you you have 10 days to respond. You respond in your time, and then you think, wow, I should get a response pretty quickly, and then it's months. And during those months, you are repeatedly getting asked by the CEO, what happened to that? What happened to that? And your response is, I don't know. It went into the government by call. And I can say that I worked for the government, so I can make. regardless. So you also, one of the things that's becoming an area where people are getting fined is background screening, exclusion screening. So I think we want to make sure that our HR folks or somebody in the organization has a policy that talks about how we're going to do that screening. Can we go to the next slide, please? So as I mentioned, with these policies, and feel free to pipe in if anybody has a thought about this, I think the bigger your entity is, the more that you have people coming in, the more you want to make sure that you're covering with your code of conduct all of those people who could really adversely affect your company. If you're a hospital system, there are a lot of people roaming around in your ORs and your buildings who are not employees. You obviously have volunteers. You have representatives from all kinds of device and implant companies who are basically teaching doctors or standing over the shoulder of doctors as they implant knee devices and all kinds of other things. They may even have some level of access to your computer system. You have medical staff members who you may own some of them, and some of them are community docs who you don't. And so as you think about it, you need to make sure that your code of conduct or some policy covers those behaviors. And I mention that because probably all of you who are from a sizable organization who have a number of people coming in have had issues with a vendor who didn't want to behave themselves, or some vendor rep who went into the operating room that they didn't belong in, thus causing probably a privacy issue or a number of things. And you want to be able to not only enforce that policy and do something about it without having to make up the rules at that point in time, but you want to be able to tell people in the first place, you should know better. And the best way to do that is, of course, to have it in your policies. Anybody have any thoughts about that? Okay.
You know, Grant, this is an area that we struggle quite a bit with, and you know, we're a little different than a provider organization, right? And we're a global organization, so we have contractors coming in software development. I have contractors rotating in global RCM. That's a little better because that's their subcontract vendor. But catching all these different contractors and getting them, you know, onboarded from a compliance standpoint, it's gotten better. But no one really wants to take a hold of it. And I'm curious to the group, if you mind me asking, how many of their HR like departments handle contractors versus, say, a supply chain kind of business services? Because in my company, which is, you know, a little smaller and different, I think I've been really pushing. I was hoping finance would take it, and HR seems to be the one getting it, but they seem to think that that puts them at different risk for handling contractors and employees. So I'd be curious to know how everyone's handling that.
So let me say that, Joshua, I've seen it handled a variety of ways, and I think in part is dependent on part of what you've touched on is the politics and who was willing to argue or stand up to vendors. In some cases, that's very politically sensitive in an organization. I think in an organization I used to be with, it was the vendor management or the purchasing arm of the company that actually had a specific process. Now, we still had issues where somebody would debate about whether was somebody a vendor or were they something else, or, you know, did they belong under somebody else's rubric? So I don't know that it ever gets solved, but I think there does have to be that conversation about who owns them as far as responsibility. And I think you've identified something that the industry is struggling with I think different people in different organizations do it differently. And if you ask me for my opinion, I think if you have a purchasing arm, they should have them because they're the ones that have the daily relationships with them. And if you move it to HR, you just change the lines of communication and then it's not as clear. And I think sometimes all you really want is your purchasing person to call their vendor rep's supervisor and say, listen, get this person in line. You don't want to make it any bigger a thing than it has to be. But in those instances, that works better, I think, if there's previously a relationship as opposed to an HR person who has no previous contact with the supervisor, calling them out of the blue and saying, hey, I need you to do something, or I want you to do something. Plus, the vendor may not think that the HR person has the power to pull the plug, which there always needs to be at least a little bit of concern on the part of the vendor that could happen, so that you get that compliance.
Grant, this is Odalis. If I could just throw in a couple of thoughts. I think that there's two aspects to this, and Grant mentioned both of them, but specifically there's the kind of setting the framework for the relationship with the vendor, and that, I agree with Grant, is the purchasing department function. I think having in my experience back in the day, a vendor certification process where in order to do business with the company, the vendors have to receive a code of conduct as part of their contract. You set them up as an approved vendor with the company. And then the second phase of that, so the expectations are set that way. And then the second part of that is the education with your team members. Because I think, I don't know that on a day-to-day basis, anybody really owns it other than the person that has the day-to-day relationship with the vendor itself, because they're the key people that are going to prevent situations from happening and hopefully communicate to the compliance office that there's a vendor that is consistently misbehaving. So I think an important part of that is really making it everybody's responsibility, not really assigning the ownership to any one particular area, because it's whoever the vendors interact with. That's just my thoughts.
And I think that is a good thought. And I will share also that when I was in in-house counsel, I probably got a call once a week from our vendor purchasing guy, because they had a lot of them. And so every week there was somebody who did something stupid. And it just happens. But I think that relationship on that side, and Josh, the fact that you're asking the question, that you obviously have been involved in this conversation, I think is an absolutely good thing, because you want those people on the front line to be talking to you so that things that need to get elevated are elevated. And sometimes it was nothing more than me saying, you do need to ask for that person to be removed because this is such a severe problem. They need to be gone. And we don't care if they go to another hospital, but they ain't going to be here. And that collegiality and backing them up, I always felt like seemed to make them feel like more comfortable moving the issue forward. So I think that relationship you've had by being involved in it is one of the other keys.
I think you guys bring up a good point, and we have, I'm working with a 3-hospital entity up in the Connecticut area right now, and we're kind of working through something a little bit peripheral to that, Josh, but they have a blank name medical center partner committee that they use, and they do that for several reasons. One is that they can have some accountability and know one person. Sometimes it bottlenecks, if we have one person who has that institutional memory about why we didn't have that vendor, why they weren't allowed before. So we have a team that kind of has some checks and balances. But they have a person on there that's on the committee that is in security, because nobody comes in without a badge, but they're not allowed to get their badge until they go through purchasing and AP finance. And the contract has been looked over with legal department. They have an HR person who does the educational onboarding and make sure that they have read their code of conduct and make sure that they understand it, be able to vet all the questions that they might have. And then that gets brought over, it's kind of a process, and then that gets brought over to risk management. Then risk management determines whether or not they need to be signing a business associate agreement or confidentiality agreement, depending on what it is, what kind of information they'd be exposed to, what kind of work they're doing. And then that all gets, after that's all done, everybody's got their check marks, then that goes to administration. Administration gives their final blessing, and then also the administrative assistant then takes responsibility for tracking that for renewals and for exclusions, because then they have a feedback mechanism whereby risk and legal, if they decide this vendor's got too many dings on them or they're kind of going rogue with their behaviors, then risk management gives the recommendation, I don't think that this person or this vendor or organization needs to be renewed, and then that kind of stays on that spreadsheet with some comments on that, so that the entire, it gives it a little bit more heft, right? Because it's the committee that's saying that they can't be on there versus, you know, politics of just one person against another. And so that's what we're dealing with right now up in the Connecticut area.
Not that I want people to struggle with the topic, but it does feel kind of nice to see that this is a general area of, I don't want to say uncertainty, but areas we're all still kind of feeling through. And one of the big issues I have, thankfully, is security is kind of covered, because any of the sensitive work in my company, they can't even get started before going through security. So we handle that area. That's how we catch the screening. It's more about the centralized kind of onboarding that we don't really have. So it's really operational. We found ways to put in automated processes to at least capture the critical compliance and security. Even then, you have these random, I mean, there are times where I have a contractor doing some development work based out of, you know, Cebu, Philippines, and one person in Bangalore put them on it, and it can fall through. So we've gotten better, but at least from the security, that would keep me up at night. I don't have that. That's the one thing that is, we're high trust, so there's no issue there. It's more about the kind of organizing it and who's willing to really take hold of it. And, you know, the latest argument I heard, and I got to give HR credit for this, was, well, if we're the ones who do it, this could be a tax issue, because we might be showing that these are employees rather than independent contractors. Now, I never thought of it like that, and I'm not in a legal position anymore, but that was a new creative argument to not take charge of this. So I appreciate all your insight on this. A+ for effort on that one, though.
But that does get back to the way to defeat that particular argument is, well, we have a policy that says you get the non-employees also. So I think that was all good conversation. And I do want to point out that I do want to have some more of these roundtables in the future. And one of the things that I really want to urge all of you is, if you have a issue that's keeping you up at night, as Joshua mentioned, please share that, and we can try to prepare that and bring that back, you know, specifically to the group to converse about. We do have a variety of backgrounds on this group. So, you know, if your organization is struggling, for instance, with a health plan because you don't understand what an IDR is and why, did I say that? Wait a minute, let's see. No, related downstream. Nicole, help me. What am I missing? I'm having a brain freeze.
FDR.
Yes, FDR. If you are struggling with FDR requirements, we have some health plan people on the call who can probably explain to you why they want that particular thing that you're struggling with. And I think sometimes that in itself helps. So in the future, if you have any thoughts or questions and you want to shoot them to us, Mary and I'll be happy to look at them and see if we can have a group conversation around them. If we can move to the next slide. So I wanted to highlight this. It is, of course, a lot of money. $112 million is not the change that you found in the couch. I think a couple things are real important here, and I think this is one of those things. I don't try to generally just bring cases to discuss that are big dollars and they're clearly criminal fraud, because the folks in our front offices, that doesn't really faze them, because what they'll say is, well, that's criminal behavior. They should go to jail. They should pay a lot of money. I like to take cases that I can think that when I was a compliance officer, they had a useful point to make. In this case, I think has a couple things to make. One is Duke University. If Duke University can get slapped for $1.12 million, anybody can, right? I mean, you can't be in this healthcare space for very long without knowing that Duke University is a big player. They have a lot of power, they have a lot of money. So that's something I always like to try to remind people about, particularly if we're talking about what's the PR effect, of getting in trouble with the government. Additionally, it doesn't tell you a lot of detail on this, but there were some like 100 or so grants that were potentially affected. There were at least 30 they identified that really they knew were. This was a lower level person who was committing the issues. And so that's one level of problem. The other thing that they mentioned in the press release and the documents that they put out about this case was Duke, the government claimed that at some point people at a next level or two up knew about it, and yet they kept submitting reimbursement claims for the research. And so I think it's important to point out to folks that it's not always what the president, the CEO, the sales marketing VP is doing. What people on the front line are doing can get you in a lot of trouble. And so that goes back to our issues about discipline, training, education, oversight, all of those things that are wrapped up in the 7 elements. So I think this is a good case to kind of make some of those points. And I think it also makes a point that once the government sees in the newspapers enough times that there's been issues with falsification of research, they're going to start auditing those things. And so if you have a research component, you got to know the government's going to be looking at that stuff. Can we go to the next slide? So this is one of those ones where it's $122 million, again, a lot of money. But what it really goes to is an issue about oversight and supervision and discharging and admitting patients. And this is a challenge that everybody has. I mean, if you have patients that are inpatient or residential, this is just an issue. And part of it always goes to the same thing. Did you document it? My friend Nicole knows this well because one of her jobs was looking at paperwork and making sure that providers documented things well. And so one of the things we all know, and we unfortunately need to repeat frequently so that everybody else has heard it so many times that they're sick of hearing it, if it wasn't documented, it wasn't done. Well, a corollary to that is if it wasn't documented well, it might be an overpayment. And so whether they did this or not, the government said they did, it would have cost them millions probably to defend themselves. And the only way they could resolve it was to agree to pay $122 million. And additionally, they would have gotten a corporate integrity agreement and all of the fun of being supervised for 5 to 7 years. And so I think this case is one of those that you can make the point for people. Documentation is important for our patients, but it's important for the life of the company also, because if it's not documented right, you're going to end up in problems. So can we go to the next slide? So this is a case that it's only at the trial level. There was a motion to dismiss filed. and it was denied. It was a key tam case. So a nurse who worked next to this doctor, apparently for some years, decided that he was performing the procedure in a way that was medically unnecessary. He was extracting heart leads rather than leaving them in. And the allegation she made was that that was because he was going to get more money out of the procedure if he took them out rather than leaving them in. I think this again highlights that we are seeing a rise in cases regarding the false claim being tied to medical necessity. This takes us right back to what I was mentioning just the slide before, that documentation. You know, did the doctor document why he decided to take it out rather than leave it in? It might seem like a small thing at that moment, but if you're looking after the fact at 5 years of somebody's procedures and they don't have that documented well, it all of a sudden becomes a pretty sizable overpayment. This hasn't gotten to the case of, to the situation where we know what the overpayment would be because it's still at the trial level, but it is a Middle District of Florida case that was just decided this summer as far as a motion to dismiss, meaning the plaintiffs tried to get the case thrown out and that was denied. So if we can go to the next slide. So there was a Monroe, Louisiana lab owner who got indicted for paying bribes. And it was $117 million that they're saying is the overpayment. This was just an indictment. It wasn't actually a settlement or anything yet. In one of those things where sometimes you just can't make this stuff up, the lab owner's name was Trey, and I'm going to pronounce his name, I think, the way it is, Fluid. I don't know if you put that in a movie script, if anybody would believe it, but he was accused of paying for DNA specimens and physician orders for cancer and genetic testing and other pharmacogenetic tests. We all know that cancer's big business now, and if you're in that business, you have to be really careful about what you're doing. Inducing people to get your referrals is gonna probably get you under the microscope. So if we can go to the next slide. So again, another organization that is well known, Baylor Scott and White in Texas. This was in their College Station facility. They were getting paid outpatient outlier payments. And this is an outlier payment is to help offset some of the unusual financial burden that comes with some of these patients. So OIG did an audit. They did 100 cases. They found that in about 18 of those cases, they were right on where they were supposed to be. If we can go to the next slide. So they determined that 18 of the 100 sampled payments were okay. On the other hand, they found that 82 of the claims were not. They had, in those 82 claims, 174 billing errors, which, because I'm a dork this way, I figured it out, that's 2.1 errors per erroneous claim. So again, one of the reasons that this all was started was the fact that the government had found that their claims for these had climbed something like 250% in only a few years. So they went from relatively low dollars to 2.5 or 2.6 million dollars in the year that they got audited. Again, what's this tell you? People are reading data. The government is looking at data. If they see substantial climbs in claims or amounts, you're going to end up on their radar. So this facility ended up on the radar, and of course, the government is, of course, wanting their money back. But again, this is a well-known company, well-known nonprofit, I believe. And again, if they're being audited, anybody can be audited. They were, of course, going after this, saying that there were inadequate controls and that there were overcharges based on observation time, charge errors, and coding errors. Those are things that can easily happen to anybody for the most part. So they are things that we always want to remind our clients, if we can call them that, about, because those are things that could happen with any claim. Can we go to the next slide? This is one that popped out at me. So the government decided they were going to start looking into telemedicine. And of course, we all know that this has actually even made the OIG work plan for this year, that they were going to look at telemedicine, particularly with a situation with COVID. We know there's been a huge uptick in telemedicine going on, which means that there's some number of people who will try to play a game and not do the right thing. So the investigators, the special agents, went to talk to this doctor, Dr. DeBlanche, and they asked her about her telemedicine consults. And she told them that in every instance, she had talked to the patient before she had issued her orders. Later, she apparently had a second thought, told him, no, I didn't always. I'm assuming this came after they had found a number of documents that kind of contradicted what she had said. The government then decided that they actually would go after her for those lies and call it obstruction of justice. So this is one of those things that doesn't happen every day, and hopefully none of you will have special agents in your facilities or talking to your folks. But it is one of those things to remind people about, that special agents have no sense of humor, and if they find out that you told them something wrong, they're not going to have a do-over. And so it is very important that folks realize that when they're talking to a special agent, that they're talking to somebody who can hold them responsible for their answers. So if we can go to the next slide. So this was a radiology center that settled a claim for $501,000. They were accused of false claims, and it was alleged that they knowingly submitted claims to Medicare and Medicare by administering dye contrast scans without direct supervision, physician supervision that was required by the federal regs, or that it was improperly billing for services performed by doctors who are not properly credentialed by Medicare. You can see how that second one happens. Somebody who was responsible for managing getting those doctors credentialed fell asleep at the wheel or intentionally did it. You hope that it was unintentional, but it is a point to make sure that credentialing people realize how important their job is to the overall claims. Additionally, doctors and other clinicians need to realize that when the federal regs or payor conditions say there's a certain level of physician supervision that has to happen, that it has to happen. Otherwise, we're going to be paying claims back. Can we move to the next slide, please? So any thoughts or questions about what we've talked about so far? So as we've kind of talked about, I'm sure all 1,000 times, you know, the difference between a compliance program and an effective compliance program can be a wide chasm. It's the difference between, you know, having a paintbrush and painting. Can we move to the next slide? So this is a case that it's a district court case out of Kentucky, but I think it was very important to show the importance of an effective compliance program. In this case, there were physicians who were accused of doctoring records. They had graduate, they had interns basically that were working for them. And if the intern did the work, then the doctor didn't get a payment. if the doctor showed that they did the work, they got an extra payment. So some of these doctors altered the documentation so that work that was done by the interns appeared to be done by themselves. The facility, it was actually the University of Kentucky, did the right thing, and they suspended and or were firing the doctors involved. The doctors actually brought litigation against the university, seeking an injunction and other relief to stop the university from preventing them from being discharged or from being removed from medical staff. And the heart of the judge's opinion came from the compliance officer's reports. And some of you may even know this particular guy if you've gone to many privacy HCCA. Brett Short from the University of Kentucky is the one who was actually the compliance officer in this. He had his folks do a very extensive job. He documented it in a report really well. That was submitted to the court, and the court upheld the suspension and terminations based on those reports. This could have actually put the facility in a substantial amount of legal peril had they not been able to fight this, because you would have all of a sudden had folks on your staff who you knew were illegally falsifying records. And so I think this really shows the importance of compliance and compliance reporting. And it's one of those things that we don't always think about, and our folks might not always think about, but where is this report I'm writing today going to possibly end up? So it is also important, as we all have probably mentioned to people, that using words like fraud or other legal terms without actually knowing the potential ramifications of those words in a report that could later get disclosed is very important. But this case, I think, highlights that issue. If any of you would actually like the opinion, I can get it to you if you want to email me. If we can move to the next slide. So I copied out a few advisory opinions. I'm not going to spend a lot of time on them. This one was a discount medical plan that actually paid chiropractors and chiropractic clinics a fee for each new member that they referred. I looked at this and I thought, there's no way they're going to approve this. Yet they did. If we can move to the next slide. They actually found that they would not issue sanctions in this particular situation. I don't think this is a case that I would regularly base any opinion on. I think it's, to me, on the outskirts of kind of logic and the reasons that I would stand on, but I think it's one good to know. If we can move to the next slide. This is actually an opinion regarding a pharmacy in a grocery store where they had a rewards program. And if you spent a certain amount of money, you could get reward points, and then you could use those reward points on out-of-pocket costs. I saw this one as probably technically an issue, but thankfully the government actually, if we can go to the next slide, allowed it. So your Publixes and organizations like that can continue to have these customer rewards out of their pharmacies. Next slide. This is an opinion I think that doesn't come up much, but is one that is good to know about. There was a seller of property who was actually on the exclusion list. And so a provider who wanted to purchase the property from that seller asked for an opinion, and was thankfully, I think, makes things a little bit easier in the world. The OIG actually said that they would not impose sanctions if you were buying a piece of property from an excluded party. And so if we can go to the next slide. So I think it's just good to know, because there could be a transaction that you have where this is true. Hopefully not going to come up much, but it is something that could come up. If we can go to the next slide. And to the next one. So this is something that has come up over the last 10 years, I think, a great deal, and it is a issue that vendors use to confuse physicians, frankly, into thinking that this is a vehicle where the physicians can earn extra money and not have any regulatory liability. Example that they give is where there's a physician who owns a pod, a physician-owned distributorship, and so the physician is not only making money on their surgeries, they're making money off of the implanted devices, because the company that owns the devices is selling them to this distributorship that's owned by the physician, and so the physician's getting a cut on that end also. Now, the problem with these kind of things is very often the physician-owned distributor or the pod, they don't have any inventory. They have only a website. The website is often linked directly to the real distributor. So when you put when you order something off of that website, it goes directly to the real distributor, who sends it directly to where it needs to be. So there's no inventory on the behalf of the physician. Physician has no employees regarding this pod. They have no real expenses. It's all really a sham of a website. But what does it mean? The physician is getting 10 to 15 to 20% cut on the sale by having this website set up. And so the government has figured out this is really a sham. I will tell you that one circumstance I did see was actually in dermatology. A dermatologist had a industrial manufacturer come to them and say, we have these skincare products. We'll set up a website for you. You drive your patients to the website to order our stuff. Anything that gets ordered through that site, we'll give you 15% of. We'll ship directly to the patient. So the doctor has no staff. They have no overhead costs. The real distributor is actually even controlling and keeping up the website, and they're shipping directly to the patients. So it's just really a way for the physician to skim some off the top. Government is not stupid. They figured this out. So they issued this a couple years ago, but I like to remind people of it every once in a while, because every time we think we've seen the latest version of this, a new version of this comes up. It is a vehicle that some of these manufacturers like to get into because they think that nobody will catch on, or they think that they'll catch on so late that the game's over. So it is one of those points to know, and if you hear a physician talking about this kind of thing, your little ears to go up and think, uh-oh, I need to know more. On to the next slide, please. So OIG posted for their fiscal year report for 2019. They are not going away. They revealed that they saw returns of 5.9 billion return for 2019. Again, that was, I think, another record-setting year for the umpteenth year in a row. So if any of our clients think that the government is going away, we can assure them they are not. This does actually also, I think, call into mind what we all on this call know and our clients will learn, which is if we get a new administration, there are going to be some changes. Some of the things will go back to the way they were under Obama. Some of them will go in a different direction. I don't think any of us think that some of the things that were changed during the Trump administration will stay that way. For instance, the 1557 provisions around non-discrimination and having ombudsmen and folks to deal with those issues. I don't think they'll stay the same way. I would expect they'll probably go back to the way they were under the Obama administration. But those are just more information that really government's not going away. They're in our business for good or bad. Next slide, please.
All right, I think I'm jumping in here. We wanted to give you kind of a summary of some of the proposed rules that are out there and that will be going into effect. This one for 2020 basically expands a little bit on the civil monetary penalties, specifically in 3 categories. It authorizes HHS to impose CPMs on individuals and entities that engage in fraud or other misconduct related to grants, contracts, and agreements. It authorizes the OIG to investigate claims of information blocking, which we'll get into the next slide, and authorizes civil monetary penalties for those, and it increases civil monetary penalties. Next slide, please. Now, Joshua, you're going to want to pay attention to this because this hits in your wheelhouse. This is the proposed rule for information blocking. The rule gives us a definition, which is only moderately helpful in that it says, except as required by law or covered by an exception, information blocking is anything that is likely to interfere with access, exchange, or use of electronic health information. The proposed rule kind of sets 2 different standards, one under 2 for health information technology developers, networks, information exchange, and a separate kind of standard for providers under 3. This will be evolving as they implement the rules and start enforcement actions, but through May of 2022, hope we get there sometime, electronic health information is limited to the health information identified as the data element, so the standard set. We'll talk about this a little bit later with some of the OCR cases, but this access to electronic health information and access to patients' own access to records has been a priority on the enforcement side, and we've seen a lot of fines and corrective action plans that have been implemented to ensure that providers and entities are allowing patient access to information. And this is kind of the next step, that the more free-flowing access to information. Next slide, please.
So we wanted to talk about a few things to consider as you operationalize your 7 elements. So if we can go to the next slide. So as we talked about before, you want to make sure you know exactly who your target population is as far as application of a policy. Are you looking at just staff, or staff and your medical staff, vendors, contractors, students, if you have students available? Joshua, I didn't know that you had an ambulance component, but I bet you probably have some students in those ambulances. Are there complex legal issues or rules that we're talking about? I'm sure none of you have ever had a problem trying to explain Stark or anti-kickback in one of your policies, because, you know, that's 2 sentences, right? How do you make that in terms that your frontline staff understand? Does the policy affect employees, or could it lead to a termination? Could it cause an overpayment? Can we go to the next slide? For investigations, audits, monitorings, those things that you want to consider in your policies is, do you have a process policy for how you do an investigation or an audit? Do you clearly say what's the difference between an audit and a monitoring? Who's getting the reporting from the results? Are you involving counsel? Drafting the reports so that people understand the danger of using legal terms like fraud if they're not a lawyer or legally trained. Overpayment determination, who makes those calls? I think most of us want to always say, not at our pay grade. Are we making those choices by ourselves? Compliance risk assessments, of course, in this overall process is one of the biggest components to me. When you're doing your annual risk assessment, and I think they should be annual because you have to have, or you should have, an annual work plan. So do you work with other partners and leaders and stakeholders to get firsthand knowledge from them? How often do you consult with them about their risks? Do you do a heat map? For those of you who are familiar or aren't familiar with the heat map, basically putting a four box chart together, and the upper right hand corner being high risk and high impact, the lower left corner being risks that are low risk, low impact, and the ones in the other corners being moderate. And the way that we've done that before is to assign values for risk and impact. You multiply those, and then you figure out what box on the chart that particular risk ends up in. When do you involve legal counsel if you're doing risk assessments? The scary thing that I'm sure keeps people like Joshua up and Karen is the first time you come into a company and you do your risk assessment the first time and you have no idea what you're going to see. Is there going to be something that, oh no, I wish I had legal on the front end of this, because it's scary. So reporting to compliance committee and the board, how does that process happen? Is legal going to be involved in looking in that, or are they going to get the report first and then try to cloak it in attorney-client as it goes to those other committees or boards? And then, of course, it should impact the development of your annual work plan. So let me just take a moment. Any thoughts or comments on anything we've been talking about? Okay, next slide. So, of course, training, we're responsibility. Go ahead.
Great. This is Adele. I wanted to make a comment on the first point that you made about getting input from stakeholders and so on. I think that is really important. I just wanted to highlight how critical that really was, to, especially in a larger organization. The people that are on the front lines are going to be the most aware of situations that they question or have concerns about. But it also stresses the importance of ensuring that you have an educated workforce, because they may not know that something is a risk if they haven't been educated on key topics. So just again, reinforcing the need for education to help with all 7 of the elements.
Appreciate that. So actually, let's skip forward some slides, because we do have a significant amount of stuff on privacy, and I want to give that some time, and we are toward the end of our time here. So one more. Keep going. Keep going. Keep going. So let's skip through these also. I'll note that there are some cases on there for you to look at. Go back one. No, forward one, my bad. Okay, Mary, you want to take over?
Sure. This is what happens when you're at the end of Grant's program. Your time slot gets squished down to something really small, but that's okay. We're going to cover a lot of this kind of quickly. And most importantly, we've done all the work here for you. It's right here in the PowerPoint. Easy reference to kind of what the current status is and some of the recent cases and settlements that have come out. So we're just going to run through some of the HIPAA enforcement actions. As you all know, non-compliance can be costly. This first one involves $6.85 million in a data breach that affected about 10.4 million people. Specifically in this case, PBC had a cyber attackers gain unauthorized access to its IT system through a phishing email, which I'm sure every compliance security professional just, is terrified at night for all those employees that are clicking on, cute cat pictures and vote for the cutest dog that come into their work email. But this particular cyber attack installed some malware that went undetected for about 9 months. And when they finally did discover it and filed their required breach report, the investigation revealed that about 10 million individuals' protected health information was compromised. The OCR's investigation found a systematic non-compliance with HIPAA rules, a failure to conduct a widespread risk analysis, and failure to implement audit controls. Next slide, please. I hinted at this earlier, but this is OCR's settled 10 investigations involving HIPAA right to access. The first one that's listed here involved a patient trying to get a copy of her medical records, and she filed a complaint. OCR gently told the provider how to get through their technical issues and comply with HIPAA, but despite the gentle nudge from OCR, the provider still did not provide the records, and a second complaint was filed. So the moral of that story is when OCR nudges you gently, you should probably comply with what they're asking you to do. Next slide. This one is one that Grant and I both have nightmares about. Beware the terminated employee. In this particular case, the city of New Haven, Connecticut, which ran a public health clinic, agreed to pay over $200,000 because it turned out they forgot to deactivate a former employee's access to the computer system, which contained protected health information of 498 individuals. And they found out that 8 days post-termination, the employee came back to the office, to her old computer, to her still active username and password, downloaded the protective health information and including names, dates of birth, and sexually transmitted disease test reports. She also shared her ID and passwords with an intern. It just highlights the importance of making sure that you have a policy and procedure of how to deal with terminating employees and ending that relationship, including any access that they could have to software that contains protected health information. Does anyone have a horror story about a terminated employee they'd like to share?
I will actually mention that, that there was a hospital system down in South Florida. I think this was probably about 3 or 4 years ago. They got fined $5.5 million, and there were 3 incidents, but one of the incidents was one of their medical staff providers fired a female employee who was a little bit angry then. They didn't take her credentials. They didn't close her out. She parked at McDonald's next to the practice the next day with her laptop and proceeded to download lots of really great PHI. They couldn't actually even tell how much that she had done on that particular day. She had actually been in so many records, they thought it might even be 90,000 individuals because she had access to the whole system. So again, that former employee thing will bite you lots.
Next slide, please. We highlighted this case just to show you that it doesn't matter. No fish is too small for the government when it comes for compliance. This was a small Metro was a federally qualified health center that provided a variety of discounted medical services to the underserved population in rural North Carolina. And despite their being a small fish, when they filed their breach report regarding disclosure of health information on access to their system from an unknown email account, they still ended up paying a fine for that disclosure. Next slide, please. So you can be as small as Metro or you can be as big as Aetna. The government does not discriminate. This was particularly entertaining only because there are 3 separate incidences that all involve kind of make you want to smack your head and say, what were people thinking? Involving data breaches. One involved, there were 2 web services had unprotected access to indexes of patient protected information that involved 5,000 individuals. They also sent out a mailing where the envelope window was wide enough that in addition to the address's recipient, it also revealed that they were on HIV medication. And then finally, they sent out a research study mailing, which contained the name and the logo of the research, the irregular heartbeat research that they were participating in. Next slide. I hinted at this a little bit earlier, but one of the initiatives that OCR focused on for 2019 is to support individuals' right to timely access to their medical records at a reasonable cost. There are 1, 2, 3, 4, 5 cases, all listed here. Can you go to the next slide, please? Basically all involving very similar set of facts. The patient requests a copy of medical records. They get no response. Sometimes it takes 2 months of no response. Sometimes it's 6 months of no response. They file a complaint with OCR. OCR gently nudges the provider to provide the records, but for some reason, the provider does not timely take the hint and ends up getting fined for delay or unnecessary or making the patient jump through unnecessary hoops in order to access their own health information. Next slide, please. So this one was $15,000 penalty for not providing records. Next slide, please. This one is a $70,000 penalty. Oh, and don't forget, you had to adopt a corrective action plan, which we all know creates its own costly and timely compliance concerns with that. Next slide. Again, this is another failure to promptly provide records. Next slide. This case involved a personal representative request for access to minors' records. So the moral kind of is all of these requests are being treated the same, and OCR is prioritizing and making a statement that patients' access to these records are paramount. Great. Do you want to add anything? Oh, next slide, please.
Yep. I think this is the message you take from this. And this actually came from the OCR posting. They basically said, we are sending a message. We're going to slap hands. We're going to get the ruler out and hit the knuckles. And I think the other lesson to take is if it doesn't work the first time, they're going to come back and whack harder the next time.
Take the hint. Next slide. We wanted to make sure that everyone was aware and had access to the security risk assessment tool that is free and posted online. They've updated it to a new version. The link to it is here. They've added some enhancements based on feedback from before, including it's easier to navigate and a little more intuitive. So we wanted to make sure that you had this resource handy. Next slide, please. This is going back to security and a little back to our employee concerns. Lifespan in this settlement paid over $1 million to regarding claims for breaches because of an unencrypted stolen laptop. I think that the laptop contained electronic health information for over 20,000 individuals, and the takeaway from this was the OCR director basically said laptops, cell phones, and mobile devices are stolen every day, and it's the covered entity's responsibility to protect patients' data. So even a third-party criminal intervening factor, if you will, does not eliminate a covered entity's responsibility to protect that information. Next slide. These are a couple more of OCR's enforcement that came out this year, but we wanted to take a moment and focus on kind of privacy and the privacy in the time of COVID, if you will. Next slide. So OCR has issued guidance on how healthcare providers can contact former COVID-19 patients about blood and plasma donations and things like that. In addition, which is available on this link. In addition, next slide. There have been a number of issues that have come up involving religious freedom and discrimination in the COVID-19 setting. Which is interesting for another number of reasons. You know, healthcare providers and entities are dealing with unprecedented is not even the word anymore to describe what we've been through in the last 6 months. And it's interesting that it's important to note that even while they are dealing on the front lines of a global pandemic, there are still constitutional rights and freedoms that need to be considered and protected. And OCR has made that clear with these 2 or 3 different settlements, or not really settlements, kind of resolutions. But to start with, this first one involves in July, the OCR's Conscious and Religious Freedom Division received a complaint from a mother alleging that after giving birth alone, she was separated from her newborn because she tested positive for COVID-19. And as her reaction to that was that she requested to have a Catholic priest come and baptize her son. But the hospital denied her that request due to the visitor's exclusions adopted in response to the early response to the COVID-19 pandemic. And after kind of mediating the resolution, OCR came out with some guidance, which is available through this link, explaining adequate and lawful access to, so kind of giving a roadmap for hospitals and providers to walk the fine line between providing a secure environment for everyone in the hospital, but also allowing for these protected religious freedoms. Next slide. In both cases, the healthcare entity ended up coming up with a revised visitation that kind of set up a protocol and procedure for patients who were in the hospital, whether they had COVID-19 or not, being able to access their religious or priests or, clergymen in order to provide their religious rights. Next slide.
So Mary, why don't we, at this point, kind of wrap up the materials that we have, because we only have 5 minutes left in our presentation, and I want to be cognizant of the fact that you all have spent your time here. Let's just start with this. I mean, do we have any thoughts or questions or anything else that any of you have thought about that you'd like to talk about in our last few minutes, or anything that you'd like to talk about at future roundtables?
This is Rachel. I think one thing that would be helpful for a future roundtable is the fact that our organization is large in size, and one thing we've been looking at lately is just making sure that we're good on documentation in the record when we're talking about coordinating the care with medical students, residents, mid-level providers, so APPs, physicians, and making sure that we don't end up with duplicate documentation, but then we're having the right person documenting to ensure that we've got the right person billing the care. I think it's a lot of coordination. There's attestation statements, and then when you talk about the use of, we're on Epic, so the functionality of copy and pasting and templates and stuff, just making sure we're good. We get pushback from the providers of redocumenting and not making their lives harder, but also then making sure that when, we were talking earlier about making sure the documentation is adequate, needing that as well. So I'd be curious to know what everybody's doing to kind of make sure they're meeting those points for the various providers.
So let me put somebody on the spot. Is Nicole still on with us, or did she bail on us? Oh, I think she left. But so if there is somebody who has something to share about your thoughts on that, please do.
I just wanted to bring up, we had when you were speaking about attestations, and I don't know who was just speaking because some people have their cameras off. So, but I work for Anesthesia Group, and recently in our Michigan hospital that we're at, we had an issue with the attestations where it was Cerner, and when they built the attestations for anesthesia, and an anesthesiologist has to, attest at certain times that they are, there during the procedure, they're there during the most important parts of the procedure, they're there, to check the patient at PACU, and then at emergence when the patient is waking up, and then also, obviously at the beginning when they're screening the patient for giving them the appropriate anesthesia. So what happened was, they had gone from the usual paper record that anesthesia does. And anesthesia is usually like the last module added for any hospital system. You're like always the last. So they took our general attestation sheet that they would normally use, put it into Cerner, and then as soon as the anesthesiologist signed in to go ahead and just do the evaluation on the patient before they were even in surgery or anything, it fired all the attestations, like surgery, PACU, emergence. That was a big, big problem. And the government looked at that, and there's not really a regulation that says that we have to do it contemporaneously, but the government said, well, you should have corrected that with the hospital. You knew that was happening because we did kind of know what was happening when we did the billing. And, there were some questions asked about it. But, unfortunately, when you talk to these hospitals and you have to change a computer system and make some sort of custom change, and it's going to cost the hospital money. Well, they don't want to do that, you know. So anyway, we battled with the government, and we did pay some money. So that's a cautionary tale, that making sure that when the computer people are putting things in, that they understand that there's certain regulations that our doctors have to follow. And if they're not followed, you're going to get dinged, and dinged big time. And, you know, I won't say exactly what we settled for, but it was millions. And the government was actually asking for multiple millions of dollars. And, you know, it's just a cautionary tale, really. I mean, you have to talk to your IT people to make sure, you know, whether they're your own employed physicians or whether they're, you know, outside physicians. I mean, I think you should still kind of try to protect those doctors and make sure that things are being done appropriately.
Thank you for sharing. And any other thoughts?
Are anyone on the team, is anyone conducting process tracers relative to risk or compliance or privacy at all? Using any multidisciplinary teams to do tracer processes to identify system vulnerabilities?
I do know that a lot of hospitals are now doing that, because Joint Commission has really made that their way that they test the compliance on the Joint Commission side. I think there is, you know, some value to being able to do some of that tracing from a compliance side. I think it's a new skill we might have to learn. I always call it the birth to death tracing, because it starts when the person comes into your care, and you don't end, you follow the whole audit through their whole time with you, be it one visit or, you know, one stay. And it's interesting because you get to see the whole process then, rather than a particular day or a particular segment of care. Any other topics that somebody would like to talk about for the future? So I'm not going to put you all on the spot anymore on that, but if you think about something later, if you want to email either Mary or I, we'll be glad to put that on the topic list for future programs. Want to thank all of you for your time today, and just stay safe for those of you who are in Florida and having to deal with the storm. For all of us, stay safe from the COVID situation. And again, we thank you all, and have a great Veterans Day. Thank you.
Thank you for letting us
Thanks for inviting us.
Great.
Thank you.
Thank you.
Thank you. Bye, Grant.
Bye.
Bye.